Hello doctors, welcome back to the channel. In the previous video, we kicked off our ultra rapid revision of ENT, starting with nose, larynx and pharynx. Today we are moving ahead to the ear part, and with this video, we will officially complete all the 15 subjects of the ultra rapid revision series. For those who are new here, let me quickly tell you what this series is all about. So it's a high yield, power packed revision of all 15 subjects in just 150 pages. Now, this is designed to help you revise again and again because, as you know, for FMGE and NEET-PG, revision matters more than how much you read. These notes include all the important PYQs, PYTs and high-yield images structured to boost your retention inside the exam hall. Now, if you want the PDF, you can download it from the link which is pinned in the comment box. Those who have missed any subjects or want to revise again, the complete playlist for all the previously covered 14 subjects is also pinned in the comments. Join our study community. The link to my Telegram group for preparation updates and discussions is there as well. If you find these videos helpful, don't forget to like, share and subscribe and drop your valuable feedback in the comments. So let's begin today's rapid revision of the ENT ear. So our first topic here will be otosclerosis. Now, how will the patient present to you? So a 25 to 30-year-old female with bilaterally gradual progressive hearing loss will present to you. And what will be the other presentations? There will be Presbycusis willisi, which means the woman will hear better in noisy surroundings, which is known as Presbycusis willisi. Also, this worsens during the pregnancy. So, the problem will worsen during the pregnancy. Here you will find positive squared sign, means there is a flamingo pink appearance in the early stage of the disease. Here you can find this is the squared sign in this image. So this is the flamingo pink appearance in the early stage of the disease. It is a very important image for your question. Now, what is the treatment? So the treatment is stapes piston prosthesis, which is also known as stapedotomy or stapedectomy. So with the help of these two methods, we can install a stapes piston prosthesis, and this is the image of that stapes piston. Next is Glomus jugulare. So here the 45-year-old female is presenting with pulsatile tinnitus. Also, there will be bleeding from the ear mass. So there will be a rising sun sign in the image. You can find this is a rising sun sign here, which means that the tumor, which is the Glomus jugulare, it is eroding the floor of the middle ear and it is invading the hypotympanum. On sigillization, what we will find? So on sigillization, we are finding that the tumor will blanch, which is known as the brown sign. Now, unsafe CSOM. So here there is a long-standing history of foul-smelling, blood-stained ear discharge. Long-standing history of foul-smelling, blood-stained ear discharge. Primary acquired cholesteatoma. So this is the hallmark sign of unsafe CSOM. Primary acquired cholesteatoma. This is the primary acquired cholesteatoma. It is the hallmark sign of unsafe CSOM. Now, if the case is of unsafe CSOM, along with that there is labyrinthine fistula. If there is labyrinthine fistula along with unsafe CSOM, so the case history will be same as above. That is long-standing history of foul-smelling, blood-stained ear discharge. But along with that, there will be another condition, vertigo. Why? Because the cholesteatoma has bone-eroding properties. Now, labyrinthine fistula is what? So, labyrinthine fistula is the erosion of the lateral semicircular canals, and it has been eroded due to the cholesteatoma because the cholesteatoma has bone-eroding properties. Next, there is otogenic brain abscess. So, otogenic brain abscess, the case history will be there is a long-standing history of foul-smelling, blood-stained ear discharge. So, same as the unsafe CSOM, same as the labyrinthine fistula with unsafe CSOM, there is again a history of long-standing foul-smelling, blood-stained ear discharge. But here, since there is a brain abscess, so there will be other presentations like headache, vomiting and convulsions. What is the most common site? So on CT scan, we will find that there is a brain abscess at the temporal lobe. So the most common site is temporal lobe. What is the treatment? Neurosurgery. Now coming to congenital cholesteatoma. So you have studied about the primary acquired cholesteatoma. In congenital cholesteatoma, there will be a pearly white mass behind the intact tympanic membrane. Here the tympanic membrane is intact, it has not perforated, and there is a pearly white mass behind the intact tympanic membrane. Then Gardner syndrome. So Gardner syndrome is also known as petrositis. What happens here? There is ear discharge, retroorbital pain and diplopia. So this is the triad of Gardner syndrome or petrositis. What is in the triad? First there will be ear discharge, then retroorbital pain, and diplopia means seeing of two images. So retroorbital pain is due to the involvement of the fifth nerve and diplopia is due to the involvement of the sixth nerve. So what happens here, you can find this is the petrous apex. The black image is the petrous apex, and at the petrous apex, fifth and the sixth nerves also get involved. So if there is inflammation, petrositis, inflammation of the petrous apex, so what will happen? There will be ear discharge. Due to the fifth nerve involvement, there will be retroorbital pain, and due to the sixth nerve involvement, there will be diplopia. Now, traumatic perforation of the tympanic membrane. Here, the treatment is conservative. We have to wait and watch, and we have to keep the ear dry. There is no treatment. Just we have to watch it conservatively, wait and watch, and keep the ear dry for traumatic perforation. Next, there is serous otitis media, which is also known as glue ear or otitis media with effusion, OME. So here the history will be that a 5 to 6 year old child with mouth breathing and hearing loss. When there will be mouth breathing, it means it can be serous otitis media or glue ear. On examination, we will find there will be air bubble. Here we can find air bubble behind the tympanic membrane. And what is the treatment? Myringotomy. Along with that, we have to insert a grommet in the anterior inferior quadrant. This quadrant is very important. Grommet insertion in the anterior inferior quadrant by doing myringotomy. Now, this is the image of the inner ear. So, in this inner ear, what you are seeing, that this is the cochlea and this is the apex of the cochlea, whereas this is the base of the cochlea. So, cochlea makes 3/4 turns, and this is the base of the cochlea, this is the apex of the cochlea, which is known as the helicotrema. This is the saccule, this is the utricle. These are the semicircular canals. So, this is the lateral semicircular canal, this is the posterior semicircular canal, and this is the anterior semicircular canal. So, the basal turn of the cochlea will sense what? Will sense this basal turn will sense the high frequency sounds, and the apex, the helicotrema, will sense the low frequency sounds. Normal cochlea, as you can see here, has 3/4 turns. If the cochlea has one turn, means less than the normal. Normal is 3/4 turns. If the cochlea has one turn, it is known as Mondini's dysplasia. Modulus is what? Modulus is the central core around which the turns form. So, these are the turns. The central core around which the turns form is known as the modulus. Now, semicircular canals will help in the angular balance. These semicircular canals helps in angular balance, whereas the saccule and the utricle helps in linear balance. This saccule and utricle contains what? They contains macule, which is the sensory end organs of the saccule and utricles. So, the sensory end organs of saccule and utricle is known as macule. Also, what happens? These sensory end organs, the macules, are covered by gelatinous layer which has calcium carbonate crystals known as otoliths. So, this macule is covered by gelatinous layer which has calcium carbonate crystals known as otoliths. If this otolith enters the semicircular canal, so this here there are otoliths. If these otoliths enter the semicircular canals, this will lead to a condition which is known as benign paroxysmal positional vertigo. So, it will lead to BPPV, benign paroxysmal positional vertigo. So, what is benign paroxysmal positional vertigo? How will the patient present to you? Here you can find a 50-year-old patient with brief episodes of vertigo, but there is a specific condition that it will change, like the episodes of vertigo will happen on changing the head position. So, this is a major complaint of the patient with BPV. Positional vertigo, in the name only you can find, on changing the head position there will be episodes of vertigo. Now, these are the two images which you can get in the exam. So, Dix-Hallpike maneuver, here there are only 2 steps, sitting and lying down. This is the diagnostic test of BPPV. And Epley's maneuver, here there are 5 steps. This is the treatment maneuver. Dix-Hallpike maneuver is the diagnostic test, and Epley's maneuver, which has 5 steps, is the treatment for benign paroxysmal positional vertigo. Now, superior semicircular canal dehiscence syndrome. What happens here? There is leakage of sound energy from the dehiscence of the superior semicircular canal, which is leading to conductive hearing loss. This is also known as third window phenomenon. We have 2 windows in the ear, the round window and the oval window. So, if there is leakage of sound energy from the dehiscence of the superior semicircular canal, it is known as third window phenomenon. Also, there will be vertigo on hearing loud sound. This is also known as Tullio's phenomena. The diagnostic test for that is HRCT temporal bone. Vertigo on hearing loud sound is known as Tullio's phenomenon, which is found in superior semicircular canal dehiscence syndrome. Then you can find these are the images of the ossicles. So first there is malleus, incus, and this is the steps. This is the foot plate of the stapes. So malleus and incus, these two, they develop from the first arc, whereas the head of the stapes, this portion, develops from the second arc, and the foot plate, this portion, develops from the neuroectoderm. So this is image procedure for syringing. What happens? The direction of syringing should be in the posterior superior direction. We should not use cold water, never use cold water for syringing, because that can lead to vertigo. During syringing, there can be a common complaint of the patient might develop cough. Why? This is an important question, why the patient develops cough during syringing, because it leads to stimulation of the auricular branch of the vagus nerve, which is also known as the Arnold's nerve. During syringing, due to the water, there is stimulation of auricular branch of the vagus nerve, which is known as Arnold's nerve, and this leads to vasovagal or syncopal episode. Also, the patient may become unconscious in between. Vasovagal or syncopal episode cough due to the stimulation of auricular branch of the vagus nerve, which is known as Arnold's nerve. Malignant otitis externa. So old diabetic, in the question you can find the hints, old diabetic patient, it can lead to malignant otitis externa. The patient will have earache, blood stained ear discharge, and facial palsy. The organism responsible for this is Pseudomonas. The facial nerve is involved, therefore there is facial palsy, and there is infection of the bone underlying the external auditory canal. Malignant otitis externa. So external auditory canal bone infection. And the first scan for diagnosis is technetium scan. For follow-up, we can do the gallium scan. The drug of choice is third generation cephalosporins and aminoglycosides. Third generation cephalosporins, aminoglycosides for malignant otitis externa. Pinna hematoma, here you can find there is a blood collection in the pinna. The treatment is aspiration and drainage. It can lead to boxer ear or cauliflower ear due to cartilage necrosis. So if this is not treated, if the aspiration and drainage is not done, it can lead to boxer's ear or cauliflower ear. Here you can find the ear is looking like a cauliflower. Why? Due to the cartilage necrosis. Bat ear. So there is absence of antihelix, no antihelix is present, absence of antihelix, the treatment is surgery at 6 years of age, which is known as otoplasty. Darwin's tubercle. So this is the Darwin's tubercle. Let me zoom the image. So this one, this is the conical elevation on the helix. This is the helix, this is the antihelix in bat ear. This antihelix you can find, this is absent. What you have to do in bat ear? Surgery at 6 years of age. The treatment is otoplasty, and Darwin's tubercle is a conical elevation on the helix. Now Bell's palsy. So what is Bell's palsy? Bell's palsy, you can find these are the features of Bell's palsy, that there will be a drooping eyebrow, drooping eyelid, facial nerve palsy, drooping corner of the mouth. This corner of the mouth is deviated. So this is actually idiopathic sudden onset lower motor neuron facial palsy. It is usually unilateral. Okay, usually unilateral. The angle of the mouth is deviated to the normal side. This angle of the mouth is deviated to the normal side, and forehead is involved. Forehead is also involved. Hyperacusis is presenting complaint. Why? Due to the loss of stapedial reflex. The stapedial reflex is lost, therefore there is hyperacusis. And what is the cause of hyperacusis? There is edema in the labyrinthine segment of facial nerve, which is the narrowest segment of the facial nerve. The labyrinthine segment of facial nerve is the narrowest segment. If there is edema, so this can lead to this following presentation. The organism which may cause this can be HSV1 virus. There is no confirmation yet, but HSV1 virus, herpes simplex virus 1, is leading to Bell's palsy. What is the drug of choice? Oral steroid for 3 weeks. If there is no recovery, then we can do electrophysiological nerve testing. First, we have to give oral steroid for 3 weeks. Next is Ramsay-Hunt syndrome. So the Ramsay-Hunt syndrome, the cause is reactivation of the varicella zoster virus reactivation. The site is the geniculate ganglion. Here the site was edema in the labyrinthine segment of the facial nerve for Bell's palsy. But for Ramsay-Hunt syndrome, the site is the geniculate ganglion. What we can find? There will be painful vesicles on the external ear, lower motor neuron facial nerve palsy. Same as Bell's palsy. It was again lower motor neuron facial palsy. Here also it is lower motor neuron facial palsy, but here you will find painful vesicles in the external ear. The treatment is acyclovir plus steroid therapy. Here you can find sagging of the face, asymmetrical muscle tone of the face. Then third one is the Melkerson-Rosenthal syndrome. So this is the Melkerson-Rosenthal syndrome. What we will find? We will find fissured tongue. In the tongue, you can find there are fissures present, recurrent facial palsy, so recurrent facial palsy, and there will be angioedema, swelling of the lips. What are the indications of cochlear implant? So if there is bilateral, means in both the ears, profound sensory neural hearing loss. Profound means more than 90 decibel. Along with that, there is normal 8th nerve. Only when normal 8th nerve is present, then only we can do cochlear implant. So bilateral deafness, profound sensory neural hearing loss means more than 90 decibel. Also, we have to do, like before the cochlear implant, we have to do the MRI. Why? To check if the 8th nerve is normal or not. Now, these are the cochlear implant. These are the external portion of the cochlear implant. And what are the parts? There is a transmitter. This is the processor. There is the microphone, and there is the battery. What does the internal component consist of? It consists of the electrodes, which is placed in the scala tympani through the round window. So through the round window, we place in the scala tympani. Auditory brainstem implant. So here you can find on the head in the brain, the electrode is placed at the lateral recess of the fourth ventricle. Lateral recess of the fourth ventricle, the electrode is implanted, and it is used in neurofibroma type 2, that is for bilateral vestibular schwannoma. 8th nerve tumor. Here the 8th nerve tumor is present. Here there was 8th nerve is normal. In cochlear implant, we have to check that the 8th nerve should be normal, but here there is a 8th nerve tumor, bilateral vestibular schwannoma, which is used in neurofibroma type 2. Also, in what cases we can use? Other cases, it can be congenital aplasia of the 8th nerve. BAHA, which means bone anchored hearing aid. There are 3 parts: titanium implant. Here you can find that this is the abutment and this is the sound processor. So what are the indications for BAHA, bone anchored hearing aid? External auditory canal atresia, there is absence of the external auditory canal. Chronic discharge of the ear, anosia with hearing loss, and anosia means one ear is absent, and unilateral severe sensory hearing loss. Again, external auditory canal atresia, chronic discharge from the ear, unilateral severe sensory hearing loss, and anosia with hearing loss. Tympanometry. So tympanometry is also known as impedance audiometry. Here you can find 3 graphs. So this is the normal graph from minus 400 to plus 200, and this is 0. So on both the side, on both the positive and negative side, it is equal. So this is a normal graph. What happens here? Here you can find it is more in the negative side and it is a flat graph. So this is for glue ear. Graph B is for glue ear, the flat graph. Graph C, what you can find, again it is more in the negative side and it is found in retracted tympanic membrane. The normal was much more higher. Here it is much more lower and it is more in the negative side. So retracted tympanic membrane, or eustachian tube dysfunction. So what you can find here, the type C graph is found in retracted tympanic membrane or eustachian tube dysfunction. A S graph is found in otosclerosis and a D graph is found in ossicular dislocation. BERA, brainstem evoked response audiometry. What we are doing here, we are giving sound to the ear and we are recording the response from the brain. So we are giving sound to the ear through this and we are recording the response from the brain. So there are 7 waves of BERA, wave 1, 2, 3, 4, 5, 6, 7. You can find this in the image, and the most important is the wave 5. So this wave 5 is the most important wave. Why? Because it is produced by the lateral lemniscus. Let's move to the auditory pathway. So auditory pathway, the mnemonic for that is E. coli, 8th nerve, C for cochlear nucleus, O for olivary complex superior, L for lateral lemniscus. This produces the 5th wave of BERA. I for inferior collicular, M for medial geniculate body, and A for auditory cortex. Now coming to audiometry. So audiometry, we have to know that up to 25 decibel is normal hearing. So 25 decibel is normal hearing, okay, up to 25 decibel. Then there is slight, mild, moderate. So these are the hearing levels. Now symbols used in audiometry: for ear conduction we use 0 and cross. So this 0 is for right ear, cross is for left ear, and for bone conduction we use symbols like this, brackets. Okay, just to know that for bone conduction we use brackets, these 2 type of brackets, and for ear conduction, for the right ear we are using the 0, for the left ear we are using the cross. Now, red line we use for right ear, blue line we use for left ear. If there is AB gap, if there is a gap between the air conduction and the bone conduction, that means it is conductive hearing loss. If both air conduction and bone conduction are below 25 decibel, so 25 decibel is normal hearing. If both air conduction and bone conduction are below 25 decibel, it is sensory neural hearing loss. Now, this is the normal audiogram. Here you can find what is the red line. Red line we have studied that it is the right ear. Also there is 0, 0. So this also means that it is the right ear, and the blue line depicts the left ear. Also the cross depicts the left ear. It is present above 25 decibels, so it is the normal audiogram. In conductive hearing loss, what we have studied, there is gap between the air conduction and the bone conduction. So here in this image you can find that there is AB gap present. There is AB gap present. This is the air conduction and this is the bone conduction. Okay, so air and bone. Also blue is for left ear, and we have studied that for bone conduction we are using the brackets. So this is bone conduction, blue means left ear. There is gap between the air conduction and bone conduction, so this is known as the AB gap. If both AC and BC are below 25 decibel, here you can find this is the AC and this is the BC. So both are for the left ear, right? Both are for the left ear because both are blue, and cross is for what you have studied. Cross is for air conduction and brackets are for the bone conduction. So both air conduction, this is the air conduction, this is the bone conduction, both below 25 decibel, both going below 25 decibel. So this is sensory neural hearing loss. In otosclerosis, there is a specific type of audiometry. So otosclerosis is actually conductive hearing loss. There is AB gap present. So there is AB gap present between the air conduction and bone conduction. There is AB gap present. So that is conductive hearing loss, and there is a dip at 2000 Hz in bone conduction. So this bracket is for bone conduction, right? In bone conduction at 2000 Hz, there is a dip. There is a sudden dip at 2000 Hz. This is known as Carhart's notch, and it is found in otosclerosis. In noise-induced hearing loss, what we find, there is a dip at 4000 Hz in both air conduction and bone conduction. In Carhart's notch, only bone conduction there was a dip, but in noise-induced hearing loss at 4000 Hz, not at 2000, at 4000 Hz, there is a dip in both air conduction and bone conduction, both air conduction and both conduction. So this is noise-induced hearing loss. Now, presbycusis, and what is the difference between presbycusis and Meniere's disease? So in presbycusis there is bilateral damage to the ear. In Meniere's disease there is unilateral damage. In presbycusis there is high frequency sensory neural hearing loss. High frequency means high frequency was sensed by the basal part. So the age, presbycusis is due to growing age. So age damages the basal part of the cochlea, and the high frequency sensory neural hearing loss is developed. And in Meniere's disease there is low frequency sensory neural hearing loss because here the apex gets damaged. In presbycusis we are finding a sloping curve. Okay, in the pure tone audiometry, if you do the pure tone audiometry in presbycusis patients, we will find a sloping curve, whereas in Meniere's disease we are finding a rising curve. From down it is rising, and in Meniere's in presbycusis it is sloping down. So this was our ear. We have discussed all the important topics which can be asked in the exam. We have discussed all the topics which were asked in the exam previously, the PYQs, PYTs, and we have also seen a lots of images in this portion. So this whole PDF is available. If you want, you can get it from the link which is pinned in the comments. The other 14 subjects PDF is also available in my website. You can join our Telegram channel. After getting the PDF also, you can click on this link and it will be redirected to my Telegram channel. It will help in your study preparation. If you don't want to buy the PDF, you can get the link from the comment box. This is my Instagram account. You can message me if you have any doubts or you need any guidance. Also, as I have already told you, the link for all the notes PDF and the playlist for all the 15 rapid revision subjects is pinned in the comment box. Thank you. Have a good day.